I think this is, this is fascinating. Thanks so much for all these really cool talks, and I'm looking forward to the rest of the whole session. So the epidemiology is it's just very clear. It's not. It doesn't look genetic. It's environmental, and therefore, when we look about race, race is a social construct. And yes, when we think about this, when we talk about risk prediction, it really isn't genetics, and it really isn't race. It really is these other surrogates. And it's certainly the surrogate for, in my mind, it looks like H. pylori, and then dietary factors, perhaps salt and other things. So I guess when we think about screening and we think about surveillance, think about where we're going with this, how do you put these together? And again, realizing that we're learning more about the social determinants of health and how what we're looking at, even though this is an Asian summit, we really are looking at race as a surrogate for other things. And so when we think about, I'm just putting it out there, just how are we going to think about now screening, surveillance, and identifying high-risk groups?
Well, that's a hard question, John. But since I'm the big picture modeler, I'll. No, it's a very good point about social determinants of health. I would only push back a little bit that I think there is a genetic component because, for example, Koreans and Japanese. There's a lot of other places with high salt diet, and I don't know if it's all environment. So I would start there. Also, gastric cancer isn't an East Asian disease. There's a high mountainous regions of Latin America, particularly the C5 region. I know Doug Morgan's here, as well as Eastern Europe. So I'm not answering your question, but it's a difficult issue. I think this issue of social determinants of health, it gets so big, it's hard to unpack a lot of this. And I think you're right. Race and ethnicity and foreign-born status is a surrogate, but I think that's what we have right now to start with. Not a very satisfying answer, I realize.
Yep. All right, so.
Thank you all for excellent presentations. I do similar research on ovarian cancer, and I'll show you some of the problems we have, and maybe you can address them. More than 25% of people in the United States are now mixed races. And so now you have a huge component that, how do you account for that? Second, we're having very great difficulties from SEER getting, in recent years, breakdown of Asian Americans. In the past, we were able to show in ovarian cancer very similar data that you show in gastric cancer, that different Asian groups have very different risk factors, but now we can't do that. Second question, colorectal cancer screening has been dropped starting at age 45. Are you going to include the younger patients in your risk models, and how will they affect that? So thank you.
Maybe I'll tackle that first question about the multi-generation. And I think that was really the impetus for when I was looking at it, more kind of naively, looking at, kind of being creative about how I'm going to capture this information, that the variables, the way we capture the information was, where were you born, where were your parents born, and then also did the acculturation variables as well, what kind of, or are you actually following the dietary pattern where you came from? I think that eventually we're gonna have to get to that complexity in order to actually appropriately understand the US population and its very ethnic diversity, in terms of immigration.
I think we're going to learn a lot by doing that.
We are. It's really tricky though, because currently we don't have such data, and as you know, with all this, especially with this immigration data, there's such security or sensitivity issues around it that it's really hard to get that information.
We also look at how long they lived in the United States.
Mm-hmm.
That was an important factor related to integrating in concentrations.
Correct.
And I want to add that in the population, the vast majority of mixed-race Asians, what's unique about gastric cancer is that the strongest disparity comes from Asian immigrants, and then the vast majority of mixed-race Asians were born in U.S., so they are already at a much lower rate.
And finally, the issue of early onset colon cancer 45. Actually, Constanza, are you going to speak on some of the autoimmune gastritis work? Yeah, so more to come, but yeah, definitely seeing an uptick in early onset gastric cancer, which might be a different phenotype of cancer. So I think we'll get more on that.
And you know, in our current risk prediction or cost-effective analysis, I think we're doing gastric cancer at age 50, but Korean screening guidelines is age 40. So if we were to follow that paradigm, then we could also shift like that justifiably.
Yeah, and I can also comment on that because we did model it really anticipating that the screening age was most likely going to be lowered for colorectal cancer. So those models all still run exactly the same with the same outcome. But that point, though, that I made about uptake of cancer screening, because a limitation of all these cost-effectiveness models is that they are hinging on that colonoscopy and really just to get that, how do you minimize cost? And so, moving away from that, because then when we do think about policy and implementation, that we already know that getting people to have a colonoscopy and even other modalities for colorectal cancer screening is already limited. So seeing how we can really address, again, that uptake. But I do also fully agree with, moving away from race and ethnicity because we know that they are surrogate markers and social constructs as opposed to having a biologic basis. And so really trying to be more precise with how we predict risk.
We have time for one more question, and there's a question over here.
Americans with missing birthplace information.
So hi Scarlett, and we applied the methods you have developed. So there are in the cancer registry, we have a lot of missingness for birthplace. So only about 60% we know from registry data where they were born. So for the remaining parts, we applied information from death certificate. So that covers about half of the missing data. Then you apply the social security number, so what age they received the social security number. So then we can kind of impute where they were born. So that is a limitation.
Yeah, so you used our approach. I guess I would just be cautious about that, especially for more recently diagnosed cases, since the Social Security Administration stopped applying that algorithm. So, and then the other comment about the question that was posed earlier about granularity of Asian ethnic information in SEER data, that is still there. It's not a problem with the numerator, it's a problem with the denominator. We don't have good population estimates past the decennial censuses for specific Asian American ethnic groups. And in fact, with the 2020 census, this is kind of a call to action for all of us since we have policy people in the room. There's going to be, we're told, a pretty huge delay in the release of those Asian ethnic specific population denominators. So those of us who have been waiting for the release of the 2020 census to finally be able to calculate cancer rates, incidence, mortality rates for Asian American ethnic groups are going to have to wait even further. And I think there's also talk about further suppressing some of that data. So I think that if there's any kind of action we can all sort of collectively take, we certainly recognize the value of this information. Of course, again, the discussion about race as a social construct, but we do still recognize that the statistics are still very important for policy making. Thank you.
Thank you so much.
So unfortunately, I know there are some more questions out there. I encourage you, I think, are we going to take a 5-minute break?
We are going to take a longer break than that. So we've come up with a solution, we think.
Okay.
It'll be entertaining, but I promise you.
So please come up, and if you didn't get your question asked, I please encourage you to come up and speak with the speakers and have a one-on-one with them to get your questions out there. So thank you all very much for those wonderful talks.